Yeah, so the POUT study was really exciting. I think it was one of the highlights of the day for urothelial carcinoma. This is a prospective randomized trial in, I think it was 260 patients with upper tract urothelial carcinoma, and this is a disease setting where we have no good prospective randomized trials, so this is a real milestone. The trial came from the UK. There's patients who had had nephrourectomy for invasive disease, so T2 to T4, pathologic invasive disease, and they could also be node positive. And they're randomized to receive adjuvant chemotherapy or just surveillance, which would be the current standard of care. And the adjuvant chemotherapy actually could be cisplatin or carboplatin, which was a controversial choice, but about a third of patients got carboplatin if their renal function, if their estimated GFR was between 30 and 50. The primary endpoint was disease-free survival, and they met the endpoint clearly. There's improvement in disease-free survival. I think the numbers went from 54% to 71% at 2 years. So that's a big benefit. Also, similar benefit in metastasis-free survival. The study was not powered around overall survival. They did present some early results, recognizing they don't have enough events, and there was a bit of a split of the Kaplan-Meier curves already. So there's some hope that it might actually show a overall survival difference. If it does, then clearly it's practice changing. If it does not, it's still hard to say that we really should give adjuvant chemo based on a metastasis-free survival or disease-free survival endpoint. It comes back to the usual question of chemo now versus chemo later, and it doesn't really tell us for sure what to do. So the authors concluded that it's practice changing. I think many people in the audience thought it's not quite practice changing.